and we'll like groups of maximum 15, because we don't think there are more than 90 people here. If there are more than 90, we'll add on an extra. So before we go for lunch, only for those who think they are going to come back after lunch, please. If you think you're not coming back after lunch because you have a flight, then please don't put your name on the paper. It won't count against you, but don't, because it will just create logistical problems for us. Yeah? So we'll go through these lectures again, 20-minute lectures, starting on the shoulder and working downwards. And then before we go for lunch, don't head off. If you're coming back, we'll have the papers 1, 2, 3, 4, 5, 6. Junior guys here, senior guys here. Okay? Is that clear? Any questions on that? Pardon? Okay, I'll repeat again. So guys, for those of you who've just come in, I'm just going to repeat what I just said, yeah? We're going through the upper limb session now, okay, lectures of 20 minutes. Before we break for lunch, those of you who are only coming back for the afternoon section, so if you have a flight to catch, yeah, don't put your names down. So we'll be having papers, three sets of papers on this side, 1, 2, 3, 4, 5, 6, yeah? Those who are junior guys, so core trainees, senior guys just for the exam, write your names on the papers here, but only put your name on one piece of paper. And if you have friends here, you want to be with them, please put your name, group together and put your names on those papers. Now, maximum 15 candidates on one piece of paper. So if you get to that paper and it's 15, go to the next one, okay? So we'll do that just before lunch, so that when we come back after lunch, we can go into the groups and then practice what we've learned this morning, because practice makes perfect. Okay, so we'll start off with examination of the shoulder, and there's no better person than Mr. Shantanu Shahani who will go through this to teach us how to examine the shoulder. I'm also going to learn from him, actually. Thank you, Shantanu.
Ladies and gentlemen, good morning again. I'm Shantanu Shahani. I work at Chesterfield. For the next 20 minutes, we will plan to go through the shoulder examination. Should be, I think. It is, yeah? No? I think so. Next 20 minutes, we'll go through the shoulder examination. This should do enough for you to go through the exam, but more importantly, for non-shoulder surgeons, this basic shoulder examination should be enough for you to carry on working in your fracture clinics and so on. Important thing is to go through all the steps. We will talk about them just now, and then we'll go through all of those again in the afternoon many times for you to reinforce the thing. Richard is one of our F2s. He's very kindly agreed to be a model for the exam. I can't show a shoulder examination just by slides like my colleagues can, so I'll just ask him to help us out. So this is what we will be going through. First three things are very simple. We'll talk about this. Then the rest is normal format. We follow look, feel, move, and these are the special tests. And then we'll finish with thoracic outlet syndrome, a few tests for that, and neurovascular status examination. Before coming to the inspection, Richard, can I just get you here? Just take the top off for me, please. Just take the shirt off me. Exposure of the patient for a shoulder examination is absolutely important. And we will see in the exam that sometimes you will have a fairly major issue with a hand problem or something. And if you don't expose all of the shoulder, which means most of your chest from the front all the way around from the side, it is extremely important to be able to do that. Thanks, Richard. So unless you're able to see all of the shoulder from the front side, it is not acceptable. Now, it's very important in exam to preserve modesty, especially if you have female patients. They should not feel uncomfortable, and you will get special gowns, etc. Just make certain that the patients are not uncomfortable throughout the examination. Okay. Stand the patient. All of the shoulder examination is done in a standing position, except, to me, the only test, which is an apprehension relocation test for instability, is done in a lying down position. That's the perfect position for doing that. You can do that in a sitting position, which we can show you later if you don't have a couch in the exam. Okay? When you make the patient stand, it is very, very important that you can have a 360 view of the patient, because a large proportion of your shoulder examination is done from the back, and you have to be able to see the scapulothoracic joint. And if the patient's standing right close to the wall, you will completely forget to look at the scapula sometimes. And rather than telling the patient, now you turn around, then you turn back again, that creates confusion. So just make certain that you can walk around the patient for examining. And then comes screening the cervical spine. We are not doing a neuro exam here. So I do a very quick screen of the cervical spine. Why is that important? We know a lot of pain around the trapezius area can come from neck, but also the suprascapular nerve innervation comes in this area. So we want to have a very quick screen to see if there is some contribution to the shoulder pathology to the neck. And it's an extremely simple screen. Just look towards me. Stretch your chin to the chest. Look up straight. Look this way. And the other side. Ears to the shoulder. And the other side. While doing this, if you get some radiation pain, some referred pain, the patient complains pre-consultation to tingling in the hand, then you have to do a full neuro exam. And you have already been shown how to do a spine exam. And that's very, very quick cervical spine. You only tell this in the exam so the examiner understands that you understand there can be a dual pathology to the shoulder. A C5 problem can create a lot of deltoid and referred pain. So it's just to explain to the examiner that you're aware that there can be a dual pathology. And then we come to the shoulder examination. For examining the shoulder, you always look from the front. What are you looking for? You're looking for the deltoid contour. You're looking for the skin condition to see if there are any scars. Arthroscopy scars are right in front. The deltopectoral, the commonest incision is right in the front. Look out for that. Sometimes you have stretch marks which obliterate your deltopectoral incision. So look out for that. Look out for bony prominences. And it's important to mention negative findings. I have seen sometimes in Richard's case, because there is nothing abnormal to see, people just keep looking, keep watching. They don't say anything. If you don't say a negative finding, the examiner doesn't know if you know what you're looking for. So it's very nice to just say, the shoulder contour seems normal. There are no obvious scars or swellings. The sternoclavicular joint, the clavicle, and the ACJ seem normally aligned. Looking from the right side, again, there is no obvious abnormal finding. Looking from the back, the thoracic kyphosis is normal. There is no winging of the scapula, and there is no wasting around the supra and infraspinous fossas. There are no obvious surgical scars. And have a quick look and say the axilla seems okay. Why is axilla important? Once I have seen a transcervical rib resection or say lymphadenopathy, it just is like a popliteal fossa of the knee, which you forget if you don't turn the patient over. And you may find a lump, a Baker's cyst. Similarly, you may find a lump in the axilla. So it's very good for completion to finish it off now so you're not forgetting it. And this was the advantage of being able to walk around the patient. Therefore, you have seen the front, back, and sides. And if you see something, say it. If you don't see it, mention the negative finding. That's very useful. And this is just to show you wasting around the fossas, prominent AC joint, loss of deltoid contour, infraspinous fossa wasting. So it's just an example of somebody whom we were planning to do a cuff repair, just preoperative picture of that. Palpation. People palpate all kinds of, you have to be having a logical reasoning as to why you're palpating something. So I just do 3 or 4 areas, feel the sternoclavicular joint, feel around the clavicle and say there is no evidence of clavicular malunion. ACJ tenderness is very important. It's the most diagnostic test for an ACJ pathology. So if you have an ACJ tenderness, look at the patient, see if it's painful. Greater tuberosity tenderness is useful just sometimes in cases of impingement. So at your level, you need to be able to say that. And sometimes people look for this parascapular tenderness. I don't think in exam it's relevant. And then confirm your findings of inspection. So if you have seen a clavicle malunion during inspection, confirm that. It is non-tender, it's malunited. Sternoclavicular joint is dislocated. So just expand on palpation what you have seen during inspection process. Now this is where sometimes things start going wrong. When you want to elicit a certain movement from the patient, the best thing to do is to do it yourself and ask him. In the exam, we see all kinds of things. People say, can you just flex your shoulder? Can you rotate your shoulder? The patient has no clue what you're talking about. So the best thing to do is to tell the patient what you want to do. Just step back a bit. Palms out. And just lift it straight. Just follow me. Lift it straight up. So Richard has a full range of painless motion in both shoulders from 0 to 180. Come down. Sideways. And keep going up. And abduction mirrors a similar picture. Come down again. Now, if he stopped at some level, then try a little bit active assistance and passive. If it is painful, stop. So do active movements, active assisted and passive in the same go, okay? You have still not gone to the back of the patient. You don't need to, and I'll tell you why. Flexion and abduction is initially done actively, but external rotation is only done passively. You don't want active external rotation. Just put the elbows by the side and just have a look how far his arms rotate and mention that. Limited external rotation in a non-traumatic condition is either frozen or an arthritic shoulder. And the differentiation between the two is by an X-ray. So as soon as you have reduced external rotation on one side and there is no traumatic history, these are your most two commonest likely diagnoses. The shoulder is either capsulitic or frozen, or it is arthritic. And you distinguish them by an X-ray. Arms behind, as far as you can go. Just turn around. This is a good way to check for internal rotation, how far the thumb goes. Then you can talk about the spine of scapula, inferior angle of scapula. This is a functional internal rotation. The true internal rotation is this movement, which is never needed for function. Whereas your functional internal rotation, that's why we check, involves extension of the shoulder, flexion of the elbow, internal rotation, CMC and wrist movements. And you can explain that to the examiner, that this is not true internal rotation, this is the functional internal rotation, which is what you need to know. Because people need this for hygiene, dressing, and all other purposes. And while you're doing internal rotation, you can stay at the back of the patient. Just lift your arms straight up again. Yeah. And come down. And lift the arms in front. And you can examine the scapulothoracic rhythm. Come down. And you can mention that during flexion and abduction, the scapulothoracic rhythm was normal. Just turn around. So what have I done? I've done flexion, abduction from the front, external rotation, internal rotation, then I've gone back, I've stayed behind, and done flexion and abduction again to look at scapulothoracic rhythm. So in one movement, going around the patient, you've finished range of motion completely. Scapulothoracic rhythm contributes to about 1/3 of your total arm elevation. So approximately, if somebody asks you 180 degrees, 60 degrees will be scapulothoracic in varying degrees. But about 120 will be glenohumeral, and 60 will be scapulothoracic. Okay. These are just to show you flexion, external rotation, and internal rotation. Now we come to impingement signs, okay? There are 3 impingement signs. All 3 signs are passively done. An impingement test is not done actively, which is Nears, Hawkins, and Scarf. And you can do all 3 in one sweeping motion, okay? Nears sign. Left hand, if you're examining the right shoulder, left hand stabilizing the scapula, right hand over the wrist, turn the arm internally. You're getting the greater tuberosity right underneath the coracoacromial arch, and then you're gently lifting it in the scapular plane and looking at the patient if he's exhibiting any signs of pain. That is Nears sign. When you've gone up and he's not painful, you keep your right arm where it is, left arm comes here, and you bend the elbow, and you look for Hawkins. You're trying to nip the greater tuberosity underneath the rotator cuff, underneath the acromion. You've still not moved your right arm. You move this here, take it across, press it, and see if patient gets a problem or pain on the top of the AC joint, which is your Scarf test. In one sweeping motion, you do all 3 impingement signs. Again, repeat. Nears, arm straight up, come down, come here, Hawkins, arm here, across, press, look for pain on AC joint. Nears, Hawkins, ACJ Scarf test. In one, it's a 15-second, you can do all these 3 tests. The impingement test is completely different, as we well know, and this is something we do in the clinic. You inject local anesthetic in a painful subacromial bursa, and these signs, well, the first 2, become negative. That's your Nears impingement test. Is that clear? These 3 impingement signs are easy. You should know what you're doing here, though. But at your level, you need to know what are you trying to do. With Nears and Hawkins, you are trying to catch the rotator cuff underneath the coracoacromial arch. With the Scarf test, you're trying to compress the AC joint, but you're looking for pain at the AC joint. So it's important to go that one step further. Why am I doing this test? What is it exactly eliciting? This is the commonest thing you'll be asked in the exam. You need to know how to examine for the cuff. What is the prerequisite? You can't have severe pain. If you have severe pain in the shoulder, you can't examine for the cuff because all signs will be positive. It's pain inhibition leading to weakness, not genuine or true weakness. And secondly, they should have reasonable passive movements. If you don't have enough passive movements, you can't elicit signs. So there are 4 tests. Let's do the supraspinatus first. Arms out in the scapular plane at about 40 degrees. There's a lot of debate. Should it be 30, 40, 60, 90? It's at about 45 to 60 degrees. Hold it there. I'm going to push down, try and stop me. And he's holding it there, and it is not falling down. Empty can test negative. Why this position? When I lift the arm in the scapular plane and turn it fully internally, I'm trying to distinguish the deltoid movements from the supraspinatus strength. And by rotating the arm internally, I'm taking the deltoid tuberosity here. So I'm putting the deltoid at maximum disadvantage. But I'm getting the supraspinatus in absolutely straight line. So I'm putting the supraspinatus in maximum advantage. That's the best you can do. You can't eliminate the 2 muscles completely. But this is the best way you can take the deltoid out of the equation and put the supraspinatus at maximum stress. You don't push here. You don't press here. Why? The triceps will compensate for absent supraspinatus. So you push above here. So you eliminate triceps to the best of your ability, and then see if it stays there. If it's a large tear, you will get a Job test positive, arm just falls down. If it's a small tear, you may have to press, no pain, it falls down, supraspinatus is most likely gone. If there is pain, you give local anesthetic, eliminate pain, and then do the tests. Okay? The next three tests, the infraspinatus, teres minor, and subscapularis, can be done in one sweeping motion again. What does the infraspinatus do? Infraspinatus is an external rotator of the arm, external rotator of the shoulder with the arm by its side. My one hand is here, and this is on the thumb. I'm holding it like this. And this is what the infraspinatus should maintain. If I let go of this and it falls down, a large tear of the infraspinatus, lag sign positive. If it is not falling down and I have to push, try and stop me. Is holding it tight? You can feel for the infraspinatus, but that's not often necessary. Infraspinatus is intact. I've not moved this yet, so I'm holding it here. I'm abducting the shoulder. Teres minor is an external rotator with the arm abducted. That's the job of teres minor. Hold it there. If it falls down, hornblower sign positive. If it doesn't fall, I'm going to push it, Richard, try and stop me. Good teres minor. My hand is still here. I've not moved it. If the pain allows, go back. Turn around for me, please. Push my hand away. Subscapularis, lift-off test. What exactly happens in the lift-off test? Why is this important in the lift-off test? If the subscap is intact, it is holding the humerus in an internally rotated position, so the fulcrum is stable. And as the humerus stays internally rotated, if that is stable, he can then, Richard, push me away, he can do this. As soon as it tries to do this, if the subscap is not working, the humerus externally rotates. And what does he do? He can't lift it, or he bends his wrist. So that is cheating. So you need to know why this Gerber's test of lift-off works. Turn around again. If this is too painful, then you put the arm in front, elbows out. Again, the humerus is being held in internally rotated position by the subscap. I'm going to try and press it to stop me. He can only hold this here and this arm to stop falling down if the subscap is working. If it is not, the subscap lets go, arm falls out, humerus rotates externally. Belly press test positive. Is that okay? So infraspinatus, teres minor, and subscap in one go. Infraspinatus, teres minor, subscap at the back. All three in one sweeping motion. Okay. There you go. Supraspinatus empty can, lag sign, hornblower sign, lift off, and belly press test. Okay. Yergeson speed tests are completely historical. You don't need that. Yergeson is resisted supination. Speed is resisted flexion. This is for biceps tendinitis. It's purely historical. They're very poorly sensitive and specific, and they're irrelevant for me. I don't think anybody should ask them. If they ask them, you can read about it. O'Brien's test is fantastic for a slap lesion. Do we need this in the exam? I don't know. But we'll teach you. It's an easy test to do. Arm in front, 15 degrees adduction, internal rotation. Hold it there. I'm going to push down, Richard. Try and push up as hard as you can. No pain, and you can hold it. If this is painful, and I turn it outside, now push up, pain goes away, slap testing positive. So what is exactly happening here? When you adduct the arm here and internally rotate, the biceps is attached to the top of the glenoid. So it's holding it. If you have a slap lesion, the biceps has come out from the glenoid. So when you try and load it, what happens? It tries to fall over the lesser tuberosity on the subscap. Patient gets pain. That's the first part of O'Brien's. Is that clear? If I rotate it outside, the biceps relocates back onto the groove. It doesn't rely on its attachment to the glenoid top. Now I'm pushing up, push up, he's happy. That tells you the slap testing, the second part of it is positive. That means there is a mechanical structural problem in the integrity of the biceps tendon from the glenoid to the radial tuberosity. You've been told just now about Dayton's hyperlaxity. You need to examine that. Selkirk's sign, I will show you. Selkirk's sign basically can be done in a sitting or a lying down position. You basically just pull the arm down, ask him to relax, and see if you get a little sulcus here. I'll show you a picture of that. It is not a pathological sign. Selkirk's sign indicates ligamentous laxity. It's a physiological sign. It may be positive in both shoulders, and it may be entirely asymptomatic. Load and shift test, I'm just putting there. You will not be asked, hopefully, to demonstrate that. But the next one is important, apprehension relocation. Ideally, you need a couch on which to sit down, lie down, and examine that. What you need basically is the scapula to be stabilized. So here I can't stabilize the scapula, but if you have something here which stabilizes the scapula, you're looking for apprehension relocation for anterior instability. So imagine Richard's lying down and you're in this position. Take complete control of this arm. I don't know if you'll be asked in the exam to do that. And holding the arm, just gently start actually rotating and keep looking at his face. If he feels apprehensive, that's apprehension positive. Relocate this back. And when you do that, you need something to stabilize the scapula. And that's why you need some scapular stabilization in terms of a couch. You need to relocate this back, and he feels better. Apprehension relocation positive for instability of the shoulder. That's the only one you need to either sit down or lie down for the patient. And that's your sulcus sign here, and that's apprehension relocation. This is exactly how it should be done because you can see the shoulder scapula is stabilized. You should be able to test the other muscles. My colleagues will be giving you talks about how to examine these three muscles from the front and these three muscles from behind. That comes more in the brachial plexus examination. Finally, thoracic outlet syndrome. Is that important? Yes, sometimes you may get a cervical rib or you may have a ligamentous band around the first rib which may cause thoracic outlet syndrome. So you need to know the two tests, Adson's for the vascular component and Roux for the neurological component. It's a rare thing, but you need to be aware of it. So if I imagine he's got a cervical rib on the right side, I've got my arm on his radial pulse, look towards me this way, yeah. Neck turned the same way, hyperextended, take a deep breath and hold it. And if the cervical rib is there, the subclavicular space is obliterated. Let go, thank you. If your pulse vanishes, it's a vascular component of the thoracic outlet syndrome positive. And the neurological component is debatable. Basically, you hyperextend and hyperabduct your shoulders, and you do this movement by which you reduce the subclavicular space and you create a neurological tingling in the hand. I have never seen that positive, but it's not a common feature anyway. No shoulder examination is complete unless you have mentioned something about the elbow, wrist, and hand. And I have seen some ridiculous things happen in the exam. We had a person who had a massive hand deformity, and he was asked to examine the shoulder, and he never, ever mentioned the hand, anything to do with it. Now, that is something you're seeing, obviously, as an inspection. So don't just be focused on the shoulder, be focused on the patient. You need to mention that his opposite elbow, wrist, and hand is fine, his opposite shoulder function is fine, and neurovascular examination. So what did we do? We exposed the patient, we made him stand, we can walk around him, we quickly screened the cervical spine, then we looked, palpated, and moved the shoulder. During moving, we did most of the movements from the front, went back to see the scapulothoracic rhythm. We didn't forget that. Impingement test, 3 tests, Neers, Hawkins, and scarf. We did them in one go. Muscle examination, cuff status, empty can for supraspinatus, infraspinatus, teres minor, and subscap. Again, in one sweeping motion, the remaining 3 tests. We did the instability testing, which was in a lying down position, apprehension, relocation, Baton's, and sulcus sign. Thoracic outlet, we know the Adson's and the Roux test. And finally, a neurovascular status. Thank you. Show them it happens in one movement, so you can show them that you know it. But Hawkins is more specific for me. Neers can be paid, is not as good. Hawkins is more specific. But it's useful to just show them. It takes 2 or 3 seconds more.
Patient between passive range of movement. You can mention and say I won't be able to do rotator cuff test.
Oh, you can say, because for a supraspinatus, you need to be able to elevate the arm to some element. For infraspinatus, you need to be able to externally rotate to some extent. I have not gone into the more details of it. Technically, if you have a reduced external rotation and you have an acutely frozen shoulder, all other tests become irrelevant. Because all the other tests will be positive. Impingement signs will be positive, cuff will be weak, and they'll be false positive. I don't want to confuse you with that. You need to be able to know what the tests are to do it, otherwise there may be potential for confusion.
Okay, just one point. Respectfully, we ask you not to video any of the demonstrations or the examiner. You can take pictures of the screen for copyright issues and so on. All of these things will be on Wikipedics, which will be part of BOA resource in the coming year. So you'll get all the video clips and all the lectures on that coming up, okay?